Hello and welcome. Today, we're going to discuss a common and often painful condition affecting the anal area, anal fissures. We'll explore what they are, why they happen, how to recognize them, and what can be done to treat and prevent them. So, what causes anal fissures? The most frequent culprit is passing large or hard stools, which can stretch and tear the delicate lining of the anal canal. Chronic constipation is a major contributing factor. However, persistent diarrhea can also irritate the anal lining and lead to fissures. Childbirth is another potential cause for women. Less commonly, anal fissures can be associated with underlying medical conditions such as Crohn's disease, ulcerative colitis, or, rarely, anal cancer. Reduced blood flow to the anal area can also contribute to the development of these fissures. Let's dive into the pathophysiology. An anal fissure is essentially a small tear in the lining of the anus, specifically the anoderm. This tear often occurs in the posterior midline because this area has a relatively poor blood supply. The pain from the tear leads to spasm of the internal anal sphincter, a muscle that controls bowel movements. This spasm further restricts blood flow to the area, hindering healing and creating a vicious cycle of pain, spasm, and poor healing. Chronic fissures develop when this cycle continues, preventing the tear from closing properly and sometimes leading to the formation of a skin tag known as a sentinel pile. Anal fissures are a relatively common condition, affecting people of all ages, though they're often seen in infants and young adults. While precise figures are hard to come by, it's estimated that a significant percentage of the population will experience an anal fissure at some point in their lives. They affect both men and women equally, but fissures caused by childbirth are naturally more prevalent in women. Constipation is more common in some groups, such as older adults and those with low-fiber diets, which can contribute to a higher incidence in those populations. The primary symptom of an anal fissure is sharp, stabbing pain during and after bowel movements. This pain can be quite intense and last for several minutes to hours. Many people also experience bleeding, usually small amounts of bright red blood on the toilet paper or in the stool. Some individuals may notice a visible tear in the anal skin. Due to the pain, there can be a hesitancy or fear of bowel movements, which can worsen constipation and perpetuate the problem. Some may also experience itching or discomfort in the anal area. Diagnosing an anal fissure typically involves a physical examination by a doctor. The doctor will visually inspect the anal area to look for the tear. In many cases, this is sufficient for diagnosis. A digital rectal exam, where the doctor inserts a gloved, lubricated finger into the rectum, may be performed, but is often avoided initially due to the potential for causing significant pain. If the fissure is not easily visible, or if there's a suspicion of an underlying condition, such as Crohn's disease, further investigations like an anoscopy, a visual examination of the anus and lower rectum with a scope, or a colonoscopy might be necessary. Anal fissures are generally classified as either acute or chronic. Acute fissures are recent tears, usually lasting less than 6 weeks. They tend to heal relatively quickly with conservative treatment. Chronic fissures are those that have persisted for more than 6 to 8 weeks. They often have thickened edges, and a skin tag sentinel pile may be present. Chronic fissures are less likely to heal on their own and may require more aggressive treatment. Treatment for anal fissures focuses on relieving pain, reducing anal sphincter spasm, and promoting healing. Initial treatment often involves conservative measures like increasing fiber intake to soften stools, using stool softeners to ease bowel movements, and taking sitz baths soaking the anal area in warm water several times a day. Topical anesthetics, such as lidocaine, can help numb the area and provide pain relief. Topical medications like nitroglycerin or diltiazem cream can relax the anal sphincter and improve blood flow, promoting healing. If conservative measures fail, Botox injections into the anal sphincter may be considered to temporarily paralyze the muscle and allow the fissure to heal. In severe or chronic cases, surgery may be necessary. Lateral internal sphincterotomy, where a small portion of the internal anal sphincter muscle is cut, is the most common surgical procedure and is highly effective in relieving spasm and promoting healing. Preventing anal fissures primarily involves preventing constipation and straining during bowel movements. This includes maintaining a high-fiber diet rich in fruits, vegetables, and whole grains. Drinking plenty of water is also crucial for keeping stools soft. Regular exercise can help stimulate bowel function. Responding to the urge to defecate promptly, rather than delaying, is important. Avoiding straining during bowel movements is also key. For individuals prone to anal fissures, a proactive approach to managing constipation with fiber supplements or stool softeners may be beneficial. The prognosis for anal fissures is generally good, especially with prompt and appropriate treatment. Acute fissures often heal within a few weeks with conservative measures. Chronic fissures may require more aggressive treatment, but even then, most people experience significant relief with the right approach. Recent research is focused on improving topical medications and exploring alternative therapies to further reduce the need for surgery. Research is also exploring the role of genetics and the gut microbiome in the development of anal fissures, which may lead to new prevention and treatment strategies in the future.